So I would like to welcome everybody tonight or respectively this morning or this afternoon, depending on where you're joining us from. This call goes from Hong Kong, basically in the east, to Los Angeles in the west. I'm Mark Schur with Ovesco. And I would like to thank everybody joining us today, especially our speakers and our chairpersons for taking the time to share these interesting scientific results and clinical data with us. The session tonight is chaired by Dr. Melissa Latorre from New York with NYU Langone Health. She's assistant professor at the Department of Medicine at NYU Grossman School of Medicine and is the section chief of gastroenterology and hepatology at Tisch Hospital. Together with her, we have Professor Jürgen Hochberger from Berlin in Germany. He's a professor of medicine and is the director of the Department of Gastroenterology, Interventional Endoscopy and GI Oncology with Vivantes Hospital in Berlin. I would like to hand over the session to you, and I'm looking forward to your moderation, not without thanking Christoph Mielke from our team, who has spent a lot of time in pulling everyone together, and thank you so much for doing that. And then over to Melissa and Jürgen, please.
Hello, everyone. It is such a pleasure for me to be here alongside all of these incredible and preeminent researchers and gastroenterologists and surgeons. So I'd like to introduce our first speaker, Professor Dr. Dennis M. Jensen. He's coming to us from California, and he is a professor of medicine at the David Geffen School of Medicine at UCLA. He is the director of the Cure Hemostasis Research Group, a principal investigator and director of the NIH T32 GI Training Grant, and an associate director of the UCLA Cure Digestive Disease Research Group. Thank you so much, Dr. Jensen, for joining us this evening.
So I'll refer to this as the CURE trial. I thank all of you for joining us, my co-authors here. As far as disclosures, we have none. This was funded by the ASGE as well as the NIH. Just to give you a little bit more background, because the others will show videos and I won't. The lesions that have arteries beneath them are part of this trial, and they include ulcers. You're familiar with peptic ulcer with visible vessel, and the real issue and endoscopic goal in this and Dieulafoy's, which also has a large artery, is to control active bleeding, which most of the time is not a problem, but most of all to prevent rebleeding by obliterating the underlying blood flow. That's our definition. The time frame for ulcers, as far as rebleeding, is 30 days. For Dieulafoy's, it's longer than that because of the recurrence rate, which is higher. I'll also remind you about how we use the classification of visual stigmata of hemorrhage. We don't use the Forrest classification, but we describe these as active arterial bleeding as distinct from oozing bleeding, non-bleeding visible vessel, adherent clot, and then flat spot. And I'll refer to those earlier because I think it's important with all treatment techniques to decide what is feasible to use and what is not. We've done studies as far as background with this Doppler ultrasound system. This allows you to identify the underlying artery to see whether it's there or not before you treat, and most of all to confirm that the blood flow is gone after your treatment. And I'll show you some data on that. In fact, here are summary data by what we consider major stigmata of hemorrhage, that's spurting, visible vessel, and clot. Before these are treated, one can detect for that whole group arterial blood flow in 87%. After visually guided treatment with multipolar probe or hemoclip, there's still residual blood flow in 27% of those folks. For lesser stigmata, which we classify as oozing or flat spot that has a positive Doppler. If you look at all of these in ulcers, 42% have arterial blood flow underneath. If you treat them with standard MPEC or clipping, none of them have residual blood flow. Those are important to separate on these trials and to understand their major differences. We have previously published in gastroenterology this trial with Doppler-guided treatment that included mostly ulcers, but a few Dieulafoys and some Mallory-Weiss tears. And you will note with visually guided treatment, severe rebleeding occurred in the standard group in 26% of the patients, in 11% of the Doppler. Why wasn't it zero in the Doppler? Well, we were afraid to, in some cases, or the investigator was afraid to apply either more thermal coagulation or to take off the clips. So that was an opportunity, we thought, to use the OTSC, which I'll give you further information on. This shows a Kaplan-Meier curve. What you should realize is that residual blood flow in the Doppler group highly correlated with rebleeding. 8 of the 9 patients with residual blood flow after visually guided treatment was finished rebled, whereas none of the ones who had no residual blood flow did not rebleed. In this trial, the number needed to treat was 7. Just to emphasize that point about residual blood flow and rebleeding, in visually guided hemostasis in a lot of patients that we've treated with ulcers, if there's residual blood flow, there almost uniformly will be delayed bleeding. If you obliterate underlying blood flow as guided by Doppler, none of the patients rebleed. And with the OTSC, importantly, in an earlier pilot that we did, why this was successful is only 5% of the patients has residual blood flow, and that patient rebled. The specific aims of this trial are listed. We actually wanted to compare clinical outcomes of the patients who were randomized to either the OTSC or standard hemostasis, which here is through the scope hemoclips or MPEC with or without epinephrine pre-injection, and I'll discuss that in a minute. The primary outcome was rebleeding from the index lesion up to 30 days, and secondary outcomes were rebleeding, treatment for rebleeding, complications, death, transfusions, and hospital days. For those of you who are interested in more details, this has been previously published in Clinical Gastrohepatology in 2021. I'm not going to go in great detail in the methodologies. This was done at 2 centers, UCLA and the VA. This was in patients with severe bleeding who met criteria. They were, it's of interest, unlike the other 2 trials, is the caregivers after the randomization and the endoscopy were blinded as to endoscopic treatment, and they made the management decisions whether to transfuse the patient more, order repeat EGD, or send them to angio or surgery. This was a 1-to-1 allocation to each treatment. For the peptic ulcer patients, that's pub patients, they were treated with high-dose PPIs for 72 hours and then BID PPIs. The outcomes were standard, followed, de-identified and analyzed by a UCLA statistician. These are important. Inclusion criteria were based on clinical parameters, which you're familiar with, laboratory evidence, including a hemoglobin less than 9 or a decrease in 2 grams from baseline, whether they're transfused or not, the life expectancy, age, written informed consent or standard. To remind you, the patients with either pubs or Dieulafoy's lesions had to have major stigmata of recent hemorrhage. That's active arterial bleeding, Forest 1A, non-bleeding visible vessel, Forest 2A, or adherent clot, Forest 2B. We also stratified by lesser stigmata, oozing or a flat spot, but they had to have arterial blood flow underneath the spot. Exclusion criteria are also fairly standard. But I would tell you, we also excluded patients who had strictures or stenosis of the esophagus, stomach, and duodenum. Some of the others included ASA scores or moribund state, shock, or survival not expected for 30 days based on their comorbidities. The consort diagram on this is that 346 patients were assessed. 200 of them were excluded on screening because of clinical and laboratory criteria. 93 who were consented were excluded during endoscopy because they did not have the stigmata. 53 met criteria and were randomized, 28 to standard, 25 to the OTSC, all completed the 30-day follow-up. Just to a little bit more detail, pre-injection of epinephrine was done with either active arterial bleeding, oozing bleeding, or adherent clot. Adherent clot before we guillotined them off and shaved it down to see what was underneath. That was not done with flat spot, but Doppler interrogation was used only in this group. If they had no blood flow underneath, they weren't part of the trial. If they had blood flow, they were randomized. Just to go back to the basics, the MPEC probe was used in this with the idea of coaptive coagulation. That is going right on the stigmata of hemorrhage, pressing firmly with a 10 French probe, low power setting for 8 to 10 seconds. And that was repeated until the bleeding was stopped and the area was cavitated. With clipping, the basic idea of this is to clip on either side of the, in this case, a visible vessel to obliterate blood flow underneath. How do you know where that is? Well, if you don't have a Doppler probe, the only other way is to use injection techniques. If you hit the artery, it usually spurts. With the OTSC, this shows a very large duodenal ulcer with a clot and oozing. We pre-inject that with epinephrine. We use 11-3A. In this case, we had some difficulty getting through the pylorus, but we were able to do it. We center this over the area, and then with extreme pushing, this is deployed over the stigmata of hemorrhage. This patient had no rebleeding in spite of this being a fibrotic type ulcer that you could not treat effectively with through the scope clips. Just to show you the baseline characteristics, I won't emphasize them. The only one that is statistically different for the standard versus the Ovesco, the OTSC group, is PTT, which was higher in the OTSC group. I would emphasize that aspirin and bleed drugs were very common in these patients, but they were not any different between the two. The ulcer size, more than 15 millimeters in size, was in about half the patients in each group. And remember, most of these patients had ulcers. As far as other characteristics, a lot of these patients were on NSAIDs and some on other antiplatelet drugs such as Plavix. Inpatient start of bleeding was seen in about 20% of the patients. The ASA scores in general were 3. What the primary results were among these patients is that they were well matched in demographics, risk factors, and stigmata. In contrast, as far as the 30-day rebleeding rate, was significantly higher in the standard group, 28%, rather similar to the cohort data I showed you with the Doppler, because it doesn't necessarily obliterate the underlying blood flow, as opposed to the OTSC, only one of the 25 patients rebled. So there's a 90% reduction in rebleed rate. It's highly significant. Number needed to treat is 4. I want to show you other results. This was not a crossover study. So if patients in the standard group bled, they were either retreated endoscopically or had embolization. But you see that rebleeding rate in the OTSC group is lower, as was the complication rate, and also the red blood cells transfused after randomization, of course, related to the rebleeding. It's important to note on this particular trial with the stratification, we were able to look at subgroups. So the OTSC only benefited patients with major stigmata, that is spurting, bleeding, visible vessel, or clot. In contrast, the standard treatment, which was MPEC or through the scope clip, worked well with oozers, that's forced 1B, and spots. In fact, none of the patients rebled. Looking at all of the patients on this trial, this shows a Kaplan-Meier curve up to 30 days about bleed-free, emphasizing the significance between the two groups, the number needed to treat, which is only 4. Two other curves of interest, though, just to show you, look at the ulcer patients alone, very similar results, and also in the statistics, the rebleed or the bleed-free group, nearly 96%. And if you look at broken out a different way, a major stigmata of hemorrhage, it's quite interesting that a major stigmata of hemorrhage, 94% of the OTSC group were free of rebleeding, whereas in that in a standard group, it was 65%. So standard treatment doesn't work as well in the high-risk patients who have major stigmata as defined in this trial. Our conclusions on this is that patients with severe UGI bleeding from ulcers and Dieulafoys, that the primary endoscopic treatment with OTSC resulted in significantly lower rebleed rates, severe complications, and fewer transfusions than standard endoscopic treatment. And this seems to relate to the overall superiority of OTSC to obliterate underlying arterial blood flow and thereby reduce lesion bleeding. So to emphasize again, patients with major stigmata of hemorrhage benefited significantly from use of this large over-the-scope clip, but those with lesser stigmata, oozing, bleeding, or flat spots with arterial flow did not benefit. The last slide here, just as an interest. For the audience, how do I look at this? And this is the professor side of it looking at. We have many treatments for this. It seems like to me, the treatments that all of us have now are the OTSC, standard hemostasis, and Doppler-guided hemostasis. And there are differences which you should keep in mind. You can have all of these in your armamentarium. Additional training, in my opinion, for managing severe bleeders is required for all of them. The endpoint of controlling success of active bleeding, if you're skilled, is more than 95%. However, the obliteration rate of the arterial flow under the stigmata is high with the OTSC and probably as high or higher with Doppler, particularly if you can use OTSC and Doppler together. With standard hemostasis, that runs around 75%. In other words, 25% of these patients can bleed. So the definitive hemostasis rates that can be expected with OTSC and Doppler are 90 to 95%, with standard hemostasis of these high-risk patients, 75%. If you look at lesser stigmata, I've shown you, all of them work. What are the potential limitations of deployment? That's been a problem if you have strictures or stenosis or their access issues, which we can discuss if you want. With standard hemostasis and Doppler, no such restrictions because you can always use a smaller scope. The time for diagnosis and hemostasis with the OTSC is longer because you go in with a standard scope and then you come back out. And with the scope loaded with the OTSC, takes longer. It's shorter with the other two. The cost of the hemostasis devices or accessories is more with the OTSC and less with the other two. And I think those are important considerations. So I appreciate the ability to be with you. I was supposed to be on a jury duty, but they let me out today to join you. So thank you for your attention and your interest in these trials.
Yeah, thank you very much for this fantastic talk, Dean. Just to start up again, we have 3 talks today. on the topic of acute hemostasis, so OTSC as first-line treatment. And so we were right into the first talk of Dean Jensen, certainly one of the world experts in that topic. But nevertheless, we would like to ask you as participants, who of you is using already the OTSC? And this is why we would like to ask Christoph Mielke to start with a little questionnaire. Who is using OTSC so far? Christoph? Can we start with a, yeah, could you please answer those questions? First-line treatment and recurrent bleeding, only for recurrent bleeding, no use in bleeding so far, used for perforation, leak and fistula. I've never used an OTSC system before.
The host
So just to
and
get
panel can't vote.
the discussion started, I'd like to ask Dr. Jensen, what is your preferred use of the OTSC system in the management of bleeding?
Well, we use it in Dieulafoy if we can deploy it. That's probably the best because that's the biggest arteries. We use it in fibrotic ulcers, where those are either primary ulcers, duodenal, or more importantly, anastomotic, where the routine hemoclipping or the cautery don't work very well. Those are the main indications. We're using it also for diverticular bleeding and other type bleeding where there's arteries involved, solitary rectal ulcers, which work well.
Dean, is not the patient himself also a factor to have a look on for, let's say, if you have a high-risk patient, if even if he has a mid-risk of rebleeding or of bleeding, wouldn't you like to have a 100% method to be sure that he does not rebleed?
Well, I'll tell you, that's why we use the Doppler. The Doppler is cheaper and faster, and you know, we're a third world country at the VA, and so you can always, they run out of these clips. You have to use what you can use. We provide the Doppler probes. We can always get them, you know, they're faster and cheaper, and you can persist on this until the signal is gone. So it's not what you see, it's what you use all of your senses, including the auditory one of hearing blood flow. If the blood flow is gone, you know, they don't rebleed. I showed you the data on it. You know, it's several hundred patients. Those are ulcers mostly, but the same thing with Dieulafoy and these other things I mentioned. So I think in a rich country like Germany, you can use whatever you want.
Well, we don't have Doppler probes in Europe or in Germany at least. No,
you should buy one. The probes only cost $150, about the same as the catheter, and the box is like $1,500. And you guys all can hear well, so you have no problem hearing the arterial signal.
This is half of the price of an OTSC.
The main, I think what you're going at is clinical judgment, which I think is fine, but you have to use evidence-based medicine in going to the best we have. And I can tell you that if there's no arterial signal under these, there's no rebleeding, you know, and it's why not extend this? You've done this with ultrasound or EUS and other things. So that's my answer. You know, I think there's more than one way to skin a cat, and you know, it's important that people realize that they have alternatives. These are easy to learn how to use. The OTSC is harder to learn how to use, and there's some access issues that you have that you're aware of that I've mentioned, and I can go into more detail if you like.
Thank you very much, Dean. Please, Melissa.
Just before we move on, could you just clarify for our viewers which specific clips were used in your study?
Well, we use the 11-3A usually, And to clarify, that's 11 millimeters in diameter. The reason we went to the 3 is the hood is 3 millimeters long, which in the duodenum gives you much better access, especially if there's scarring and so forth, or whatever. In the stomach, it doesn't matter so much. You can use the 6. Why the A? The A doesn't have sharp teeth, and a lot of our patients I've shown you are on bleed drugs, and if you touch the mucosa, you get secondary bleeding, and it turns out in a closed space to be a real mess. So in the pilot study, we used all different types, but that's what we came upon. One other thing, if you have an intubated patient, for whatever reason, and you're trying to pass this or a banding device, you often have trouble and you have to let down the cuff. So it's not a stenosis, it's, the balloon of the endotracheal tube can compress the esophagus too. So you have to be careful, and because of the way the tip of this is designed, the OTSC, you can get in these bleed patients, you can get some mucosal trauma if you try to push through. So there are some issues, access issues, learning points. These are not always easy to use. And we try to teach all our fellows how to use them, but it is a major challenge because unlike what Jürgen had with these models and so on before, there's nothing like doing these in actual patients. There's no substitute.
That's certainly a very important. Excuse me, Melissa.
No.
I think this is a very important point. I think to put some jelly, let's say, on the outside of the clip before you introduce this is extremely important, not to injure the upper esophageal, the mucosa and the upper esophageal sphincter. But to tell you the truth, I have personally certainly fired more than 800 or 1,000 clips within the last 12 years. And we had the first ones here in Europe. And so this is not a major point, but it's great you mentioned that the short tip of the clip may make a difference in duodenal ulcers. For you're much more versatile, you can much better angulate.
And also in anastomotic ulcers, which whether it's obesity or standard ulcer surgery or whatever, that it can be a real problem because of the surgical anatomy.
So we'll be getting to more tips and tricks from our experts in the discussion at the end. And I think we can move on to our second talk.
Yeah. So next, I'm very happy to introduce the next speaker, Karel, who was like myself, president of the German Society of Endoscopy a couple of years ago. And in Germany, he's very well known to be extremely active in studies and really good prospective comparative trials. And Karel, it's a pleasure and an honor to have you here. And you will talk about the STING-2 trial.
Yeah, Jürgen, thank you very much for the very nice introduction. And thank the hosts for giving me the opportunity to give this talk. So let's start this. My topic is the OTSC as first line in nonvariceal upper GI bleeding, the German multicenter randomized controlled trial, the STING-2 trial. And as we all know, these are my disclosures. It was published last year in GUT in July and was a work from 9 different German centers. As you know, the over-the-scope clip, the OTSC, is very effective concerning closing of fistulas and also in hemostasis. This is probably due because it has a high compression force, it holds better in fibrotic tissue, and the cap allows a better visualization and accessibility to a bleeding vessel. We have conducted the STING-1 trial where we looked at recurrent bleedings. We randomized 33 patients receiving either standard therapy or hemostasis with OTSC in patients with recurrent peptic ulcer bleeding. And also this first one trial showed superiority of the OTSC because in the standard group with injection and clipping, there was a further bleeding rate of 57.6%. And in the OTSC group, there was a further bleeding rate only of 15.2%. So there was a relative risk reduction of rebleeding of 73.6%. From this point on, we were wondering if we could bring this in first-line treatment. And as you know, nonvariceal bleeding is still a common clinical challenge, especially since the cardiologists are putting so much anticoagulation drugs into people. The endoscopic standard therapy is through the scope clips or coagulation in combination with submucosal injection. The over-the-scope clips, as I've shown you, have been shown to be superior in the randomized controlled trials for recurrent peptic ulcer bleedings. And in the beginning of the trial, the role of the first-line treatment OTSC was unclear. And so the aim of the study was to compare first-line OTSC treatment with standard treatment in patients with acute non-variceal upper GI bleeding. The design was a prospective nationwide multicenter randomized controlled trial. The standard treatment included application of at least 2 through the scope clips. Was in the protocol enough effort should be put into applying the clips, or a coagulation in combination with submucosal injection of diluted epinephrine. At this point, I must say OTSC rescue therapy was allowed due to ethical reason in case of further bleeding. The OTSC arm was, of course, application primarily of an OTSC. The patient group was an acute non-variceal upper GI bleedings with a high risk of rebleeding defined by the complete Rockler score equal or larger than 7 points. The hypothesis was that the OTSC would be superior at least 20% compared to the standard therapy. We did a patient size calculation with a power of 80%, an alpha error of 5%, a beta error of 10%, a significance level of 0.05, and therefore 46.5 patients were calculated in each arm. Therefore, the study was designed for 50 patients in each arm. The inclusion criteria were patients with endoscopic evidence of acute non-variceal bleeding and high risk of rebleeding. The complete Rockler score greater or equal 7. Exclusion was variceal bleeding, tumor bleeding, or surgical therapy. Of course, other points is age less than 18 years. A second look endoscopy was mandatory within 72 hours. Follow-up was done for 30 days by phone interview. The primary endpoint was a composite endpoint, was clinical success defined as successful hemostasis without evidence of recurrent bleeding. Secondary endpoints were mortality, adverse events, further bleeding, transfusion, inpatient days, and salvage therapy. This is the complete Rockler score, which is very well validated and shows you it consists of the age, of signs of hemodynamic suppression, comorbidities, and endoscopy stigmatas. And if you have a Rockler score larger than 7, then the rebleeding rate, according to this paper from 1996, is considered to be 43.8% and mortality 27%, which may be a little bit too high, as we have seen now in our study. So now some definitions is acute non-variceal GI bleeding and Dieulafoy's lesions were also included. A persistent bleeding was designed, was considered if there was a present bleeding at the conclusion of the index endoscopy, a recurrent bleeding within 7 days, and late rebleeding at the days 8 to 30, and further bleeding after 30 days. The peri-interventional management was, of course, PPIs, EGD done in deep sedation. The management of the anticoagulants was according to the current guidelines. H. pylori was eradicated if detected. The management of further bleeding was a secondary endoscopic attempt, and the technique was a choice for the discretion of the endoscopist. So now coming to the results section. We screened 246 patients for eligibility. Non-included were 146 patients because they did have either no bleeding source detected at the index endoscopy or they met some other exclusion criteria. Then it was a written informed consent obtained when the patient went into the endoscopy and the patient was randomized after the eligibility was confirmed during the endoscopy and an envelope was opened for randomization. 52 in the standard group, 48 were randomized into the OTSC group. There was no loss to follow up. Now, the patient's characteristics were well balanced. The median age was 79 and 78 years with a dominance of male sex. About 20% had a history of peptic ulcer disease, and number of hemodynamic instability was 55 versus 60% at presentation. Complete Drucker score was at a median of 8 in both groups. 46 versus 37% had 7 points, and this was also well balanced. The location of the ulcer was mostly in the stomach and in the duodenum. And there were 1A bleedings in 20%, 1B bleedings in 50%, and 2A visible vessel and evidence of bleeding in about 30%. The endpoint was met in 38 patients, 73% in the standard group, and in 91.7, 44 patients in the OTSC group, which was statistically significant, and therefore the study has to be considered as positive. The number of OTSC deployed was 1, of course, in the OTSC group. The TTS group were 2 clips applied each. And the only difference was the injection volume, 10 milliliters in the standard group of diluted epinephrine and 5 milliliters in the OTSC group. Persistent bleeding defined as ongoing bleeding after end of the endoscopic intervention was 0 in the OTSC arm. So the OTSC stopped the bleeding in all 48 patients. In the standard group, 6 patients had persistent bleeding, and they were switched to OTSC therapy as salvage, and none of them rebled until day 30. Recurrent bleedings happened in 8 patients in the standard group and 4 in the OTSC arm, and all could be managed endoscopically, except 1 where has to go to surgery in the OTSC group. Late rebleedings after day 8 happened only in the OTSC group, and those were 2 of them, and they were all after day 14 and after day 10, and they were all managed endoscopically, one with coagulation and the other one with a TTS clip. So the total rebleeding was 14 in the standard arm, 6 persistent, 6 persistent bleeding and 8 recurrent bleedings, and only 6 in the OTSC arm, and we had only 6 recurrent bleedings. There was no difference concerning number of blood units transfused, no difference concerning ICU or hospital stay in the 2 groups, and also there was no difference concerning the time for the procedure. So OTSC was not more time consuming. There was no difference in the mortality rate. There was no difference surgical therapy or other SAEs. So in conclusion, the OTSC first-line treatment, from our point of view, should be considered standard treatment in patients with non-variceal upper GI bleeding and high risk for rebleeding, as defined by the Drucker score, equal or larger than 7 points. The primary hemostasis with the OTSC is extremely high. There was no persistent bleeding the OTSC arm, and also the OTSC salvaged all 6 patients with persistent bleeding in the standard therapy arm. And it's also shown in this study, confirming the high efficacy of the OTSC application as salvage therapy, because it was successful in all persistent bleedings, was successful in all recurrent bleedings in the standard therapy group. And as I mentioned, there was no additional time consumption using the OTSC. There was 28 minutes required for standard treatment and 27 minutes required for OTSC application. There, as I mentioned, there was no difference in secondary endpoints concerning complications, blood transfusions, hospital ICU stage, surgical salvage, 30-day mortality. There may be some limitations to our study considering the endoscopist training, but I think that nearly every endoscopist who is handling patients with GI bleeding is nowadays well trained with the OTSC, and there may be this OTSC salvage bias because OTSC was allowed to salvage a failed standard treatment arm, but this was due to ethical reasons. I want to say special thanks to the people in Ludwigsburg who done the bulk of this work, especially Dr. Meyer, who conducted the study, Sabine Wennemuth, Sandra Wennemuth, who did the data handling, and Dr. Vanhoff, who was also very busy on this team. And also thanks to all the other centers, and especially Ovesco Endoscopy, especially Mark Schur and Frau Stritzke for their help and for their help in this study. Thank you very much.
Thank you very much, Karel. Wonderful talk. Melissa.
Okay, we're back.
I think your question was, what about complications concerning the use of OTSC? I just saw in the chat, Melissa.
Oh, yes, there are some questions that we are going to address at the end with all of our panelists, just to get their thoughts. And I guess we can lead with that question. Any complications from the use of OTSC?
Did you have any severe complications, Karel?
No, not in this study, and also not in the Sting 1 trial. We haven't seen any perforations or any major complications. Not really. We had also no stenosis, so it's always fear that you would, if you have duodenal ulcer and you clip it with the OTSCs, you may make a stenosis. Never seen a clinical significant stenosis during my treatment.
Yeah, I think we can talk about the tips and tricks also, which kind of endoscope to use and what to do if there is kind of a pyloric spasm and so forth. We can talk about that a little later.
And tell us, for this study, which was your clip of
Melissa?
choice?
I could not hear you.
Which clip is we used the type 1 clip.
Any specific reason why that was the clip of choice for this study?
To have a better clipping was considered to be a better clipping effect, holding in the fibrotic ulcer.
So we're definitely going to have you and Dr. Jensen debate this topic of whether using the type A or the type T over the scope clip. And we'll get to that a little bit later in our discussion with all of our presenters. So thank you so much, Dr. Caca. And I'd like to move on with our third and final presenter and presentation. And we're taking note of all of your comments in the chat, and we'll bring those questions again to our plenary discussion. It's my pleasure to introduce Professor James Lau, who's coming to us from Hong Kong at Prince of Wales Hospital, Chinese University of Hong Kong. He is the chairman of the Department of Surgery. He is also the Yao Ling Sun Professor of Surgery and the head of Division of Surgery Graduate School at the Chinese University of Hong Kong. Thank you so much, Dr. Lau, for joining us. And this is the world premiere of his data, and we have some videos to include. So this should be also another exciting talk.
Thank you. It's an honor to be here. Thank you for your introduction. So let me start by showing a video. This was a patient that came to us with a hemoglobin of 3 grams. She was hypotensive. She was resuscitated, and then she came to endoscopy suite. So this is what we saw. So we just went through the pylorus, a very large bulbar ulceration, and a very large vessel. The question to the audience is, what is the endoscopic treatment of choice? So this was a question. I'll tell you what we did at the end of the talk. We started the randomized control study was back in January of 2018. We started it as a single center study. We obtained a grant from the University Grant Council. And subsequently, a number of endoscopists from China were interested, and they actually contributed a number of cases, but there was a supply issue of OTSC into China, and they stopped. So Prince of Wales was the center principally contributing the number of cases to the trial, and Dr. Alan Moss from Melbourne actually contributed cases as well. So our hypothesis was OTSC was superior to standard therapy. Standard therapy being thermal probes 3.2 millimeter and the standard through the scope clips with or without epinephrine pre-injection. Our primary outcome was control of bleeding over 30 days, and we calculated our sample size to detect a 15% difference. We needed about 80 patients per group with an alpha, two-sided alpha of 0.05 and a power of 80%. This is a diagram to show the participant flow. We screened almost 700 patients. We, in fact, obtained consent prior to endoscopy. 510 patients provided endoscopy, and many of them did not actually come into the trial because they were lesions with minor stigmata or not bleeding at all. They were patients with esophageal gastric varices or GI tumors. So in the end, we had 191 patients randomized, and one was excluded because the patient had prior embolization. So this is a table just to show that the randomization was successful. The two groups are balanced in age, around 60, mean age of 60 to either group, 80% men. Mean hemoglobin was 8.4, around age to both groups. And 1 in 6 patients were in hypotensive shock with systolic blood pressure lower than 90 millimeter mercury. We also enrolled in bleeders, and these were patients admitted for reasons other than bleeding and subsequently developed bleeding within the hospitals, and to each group about 1 in 8 were in bleeders. The median Glasgow Becher score was 11 and 12 respectively. 90% of our cohort were bleeding ulcers, and about 50% were duodenal ulcers and some gastric and anastomotic ulcers. We also included a handful of Dieulafoy lesions and miscellaneous lesions. So here's a Kaplan-Meier curve to show our primary endpoints. With the use of OTSC, the control of bleeding was in 96.8 patients. In fact, there were only 3 events in patients treated by OTSC compared to 85.4% in patients who received standard therapy with a hazard ratio of about 0.2 or 5. So here's another way to look at it. OTSC, the control of bleeding was 97% compared to 86% in the standard therapy group. With the use of OTSC, there were only 1 failure to achieve hemostasis at the first endoscopy. This was a gastric ulcer, and there was some ongoing bleeding in spite of the OTSC, there was some oozing. We added thermocoagulation, and we actually stopped bleeding, but it was considered primary failure. And there was also 2 recurrent bleeding after OTSC, one with a large gastric ulcer needing polyagastrectomy, and the third patient was on enoxaparin because of deep vein thrombosis. He bled on day 7. So all in all, there were only 3 events in patients who received OTSC. We also did some subgroup analysis, and these were pre-planned. Peptic ulcers and Dieulafoy lesions, 90% majority of the lesions, and we divided the ulcers into different categories. And you can see that the patients with larger ulcers, 20 millimeter or greater, only 1 in 10 in the OTSC group we bled, compared to the 5 in 9 of the patients in the standard therapy group. When we calculated NN, the number needed to treat was 2. And also when you look at the Forest 1A bleeding, in fact, OTSC was better in control of spurting hemorrhages. Only 1 in 10 had further bleed compared to 40% in the standard group. Again, with a very low number needed to treat. The other group that had moderate effects, moderate benefit with the use of OTSC was the group with vessels, Forest 2A. These were non-bleeding visible vessels, and there were only 2 events in 58 patients compared to 9 in 56, with the NNT of about 8. Numerically, we saw fewer patients who needed transfusion and lower mean red cell transfusions and so on. And none of this, in fact, reached statistical significance. Of course, there were fewer interventions for recurrent bleeding in patients randomized to OTSC. We had 2 deaths in the OTSC group and 4 deaths in the standard therapy group. We also calculated the cost to avert 1 episode of bleeding. And of course, this was local health cost data, may not be applicable to other countries. But we saw a marginal benefit with the use of OTSC, marginally cheaper with less than $100 US with the use of OTSC. So our conclusion was, I think OTSC should be considered initial endoscopic treatment in larger ulcers, a bit like the ones that I show you, and also with spurting hemorrhages for Forest 1A, and also with non-bleeding visible vessels. So going back, I show you how we managed that particular patient. The patient was in fact in the trial, and this was we used an OTSC, and you can see the clip actually going, incorporating the vessel very nicely, and the patient's recovery was uneventful, and she went home. This patient was not in the trial. This was done in 2014, and this was a patient who, in fact, had prior embolization, and because of recurrent bleeding, and then he actually went home and then came back with more bleeding. So this is what we did. In fact, we repeated his angiography to show this was a pseudoaneurysm of a pancreatic duodenal artery, and we used the OTSC to treat this one. We actually centered the vessel within the OTSC. We were a little, the edge of the cap was actually scraping the vessel, which started the bleeding, and the bleeding became more severe, and I needed to adjust the OTSC to center the vessel within the transparent hood, and then by the pull of the string that the clip was deployed. It's important not to move, because you lose your view if you actually take the cap off. You just need to adjust the position of the cap. again, this was another one, and this would be one that I would use OTSC as a primary therapy. This is not difficult to show in a clinical trial, but you can appreciate the size of the vessel, and the ulcer was in the back wall of the duodenum. This is would be a very large vessel erosion, and I think one could argue using primary angiographic embolization in such a case. We decided then perhaps we should try the OTSC. Again, with just gentle suction, the bleeding started. But it's okay if you keep your cap in place, and then I'll show you the end results. And the clip was deployed, and then you can see the pulsation disappeared. Then with the clip encircling the vessel itself. So this is the end result, and you can see the clip going around the vessel with the pulsatility disappeared. And the last category of cases that I would use OTSC as a primary therapy is a Dieulafoy lesion, as suggested by Dr. Jensen. And classically, they are located within 5 centimeters of the gastric cardia. And in this particular patient, we tried multiple clips, and then there was ongoing oozing. And it was just easy enough to deploy an OTSC. And you don't need to take off the through the scope clips, and you just have to put your hood around the clips and aspirate the mucosa into the hood and deploy the clip with the with all the other through the scope clips within. And you can see that it's nicely treated. The reason why we use OTSC in Dieulafoy lesion is in the left, and this is a classic picture of a Dieulafoy lesion, classically described as a lesion within 5 centimeters of cardia. And usually you don't, sometimes you see an ulcer, sometimes you do, but histologically, you in fact have very thick tortuous arteries with thick walls within the submucosas. And to incorporate the submucosa within the clips, and I think only OTSC can actually work. So this is one category of lesions that I would definitely use an OTSC. With that, I end my presentation. I love to discuss further with you about the use of OTSC. Thank you very much.
Thank you very much, James. Wonderful presentation, which showed also the difficulties that you may encounter, let's say, in ulcer treatment.
So we have about 11 minutes until the end of the webinar, and I'd like to just invite all of our presenters back for our plenary discussion. And we have a lot of great questions that have come through in the Q&A. So we'll try to get to all of those if possible. One of the first questions that came up was whether to use any kind of the accessory or anchoring devices, and what are your personal preferences or recommendations from our presenters? What are your thoughts?
If I can try answering the questions, I've used anchor device on some occasions. Where if I have difficulty positioning the cap onto the ulcer, then I would use the anchor device to puncture not into the vessel, but next to the vessel, and gently pull the ulcer, or gently glide the cap onto the lesion. Positions would be something like towards a lesser curvature, and sometimes high in the angular notch. And sometimes that would be required. So I've actually used that in some occasions. So mostly when you have difficulty positioning your cap, and the anchor device would certainly help you.
We don't use the anchoring device after hitting an artery a couple of times in different patients. we wouldn't use the anchoring device unless we used a Doppler probe to see where the artery is. And as mentioned, you can trace it. We found it unnecessary, particularly with the shorter caps in the duodenum or with anastomotic ulcers. Of course, in the stomach with Dieulafoys or gastric ulcers, we use other larger caps, especially with the Dieulafoy, the 6 millimeter cap, still 12 or 14A, 6A, for reasons that I told you about the trauma.
We use the anchoring device rarely, but sometimes, as Professor Lau mentioned, if the bottom of the ulcer is too rigid and you cannot pull in anything, so then we, of course, not to hit the artery, try to pull a little bit of tissue inside of the cap, so we can grasp some tissue at the bottom of the ulcer.
So some of the other tools that are available are also the graspers. And then, in the rare event of a complication where the lumen is obstructed, there is the device to cut off the over-the-scope clip. So just for our audience to be aware that there are other tools that come with the over-the-scope clips. I guess the general consensus here is that suction is sufficient in most cases. And one of the questions that also came up in the chat was whether you need a complete blackout or per se and bleeding red out demonstrating good suction in order to deploy the clip. And I would say it can be difficult to achieve, and in contrast to a bander, which is very easy to suction a varixin. But as best as you can achieve that suction to help pull your stigmata into the clip, I think would be the most effective way to deploy, but not 100% necessary. And as the data has shown, despite very large and fibrotic ulcers, we've had excellent results with the over-the-scope clip.
Your goal is not to close the ulcer. Sometimes people think they have to grasp the borders of the ulcer and somehow close the ulcer. Your aim is to grasp the vessel at the bottom of the ulcer and clip the vessel. So you rarely get a complete red out.
Make a comment
except it's bleeding like hell.
I think it's very helpful to have one person deploying this and the other pushing quite hard into the base while you have high-grade suction. And on these fibrotic ulcers, of course, you cannot suck the tissue, but if you center it well and you have the shorter cap, particularly in the duodenum, these things are like a bear claw. They do dig in and they are quite successful. With soft lesions, that's unnecessary, soft mucosa, smaller ulcers or Dieulafoys. You can suction them in and get a red out. And as we've seen on Professor Lau's videos, you don't want to have it too red. You don't want to suction the artery, pancreatic or duodenal, but if you're good like him, you can stop it anyway.
Mm-hmm. So that's a great point, and also brings us to one of the other questions about the learning curve for the over-the-scope clip. I'd like to pass it along to Dr. Hochberger to comment on some tips and tricks on learning and kind of his experience as an experienced user and teaching this to other people.
Yeah, as I said, I think the most important thing is to put some jelly as you use it for a colonoscope. And you told me, Melissa, that you're using that also for the banders, which we would not use for banders, for we would be afraid that the bands would slip off. So in every case, for the introduction of the scope, that's important. It's important that you have a treatment, a therapeutic scope with an 8.3 millimeter channel. Of course, that you don't start with a standard scope with 2.8 millimeter channel. And yeah, of course, I think it's rare that you need the anchor, but it's of course a tool if the ulcer base is very fibrotic. In some patients who have a very large stomach, you could even consider, if not to take a 130 centimeter colonoscope, so a M-type colonoscope, if you don't pass really the pylorus for it's too spastic, but it's very rare you need that. We were discussing about which is the best type to use. James, what is your preference? Traumatic, atraumatic, for what kind of ulcer?
We use the T type 11T. We use 11 because it can be fitted into a small scope, GIF 9mm scope. A T because early days when we use the atraumatic ones, the clips come off, particularly when you angle your scope and you're trying to put clips onto the back wall of the duodenum with small ulcers, they come off. So I use the sharp teeth because they actually anchor very well. So that's my experience, not to say that it's necessarily true.
Now, do you use the 6 or the 3? You know, the tip.
With a short cap?
Early days, we only had the 6. Now we have the 3. They're different. With the 6, you tend to see a little bit better because you are a little more distance away. So yeah, I use the 6, but I think a 3 is okay too.
So just to clarify for some of the users that may not be as familiar with the Ovesco devices, but the first number, the 11 or the 12, really specifies the diameter of the scope that and the cap. So the 11 fitting on a standard scope, the 12 fitting on a therapeutic scope. And the second number, the 3 versus the 6, is the distance of the clear cap. And then the A, the letter or the following letter, the A or the T, indicates the type of teeth that are present on the clip. So the A being the atraumatic, the blunt teeth, and the T being the traumatic, or we're going to see a pointy little sharp tip on the point of it, on the end of every one of the spikes of the clip. So classically, I think the idea is that the teeth, or the T, the traumatic, is preferred for fistulas and for areas where there's fibrosis, and the atraumatic for areas of bleeding. But really, they're both effective, and that's why we bring it to our panelists to give us some of the nuances as to their decision making and for their individual studies.
Yeah, that's very interesting. So I think it's currently open, even though we have in Germany currently a study. I cannot talk about the results so far, but it, let's say the atraumatic for duodenal ulcers looks good, especially concerning the rebleeding rate, but both work in every case.
Another question that came up, which Dr. Jensen, I'll throw this your way, is whether to use the clip with or without epinephrine or adrenaline, depending on where you are. And what are your thoughts on that? And then we'll go around and ask our panelists.
Well, with both the OTSC and standard treatment, as I showed you on the slide, anybody that has bleeding that's active, whether it's forest 1A or B, we use it. And then an adherent clot, we pre-inject, usually with 1 to 20,000 epinephrine, 4 quadrants around, and then cold guillotine off the clot, particularly if it's a larger one. But we don't routinely use it for non-bleeding visible vessel cases because it's unnecessary. Now, sometimes when you suction this, you do start getting bleeding, and then you can always use a little bit more epinephrine. You can inject it afterward. And as mentioned, I think by Professor Lau, sometimes if you have the OTSC and you have bleeding still from the middle, you can inject or use a cautery probe, you know, the 10 French probe, and clean up the bleeding. If you have continued bleeding in the middle of it, you haven't gotten rid of the underlying vessels. So firm tamponade is necessary in those cases. It's not very, the thermal does not work well for Dieulafoy lesions related to the histopathology that has been shown by me and James, because the arteries often are bigger than 2 millimeters and they ramify. So we, in those cases, often use a larger clip and often a 6A, you know, whether it's 12 or 14 millimeters, as we do with some gastric ulcers, and then these diverticular bleeds that we're using a colonoscope.
Interesting.
So we're using epinephrine just to calm the bleeding down. We just don't want to inject too much at the base, because we're a little bit afraid that you have lots of edema and you don't grasp enough tissue. So we should try, if possible, not to inject too much, but only just for cleaning up and to making the vessel visible, and the point where you want to put your clip on. But we're not trying to over-inject. So we're always afraid that we wouldn't grasp enough tissue.
James, are you not afraid that with the smaller scopes you have not enough suction? Is that a point?
You mean I don't use a large scope. I think a small clip actually works better. I don't know if I understand your question completely. But with a smaller GIF scope, you tend to go around a little easier, particularly in tight duodenum, you actually go around a little better. I don't think it's necessary to use a larger cap and a larger clip because the spaces can in fact be quite narrow. So I don't know
what if it's actively bleeding and you don't see much? So if you have a small channel, so standard channel scope, isn't that a difficulty?
No, I actually quite like bleeding because if you center your cap over the bleeding, you can actually see a lot of bleeding coming into the cap. A bit like the video that I show you, that's actually a good sign that you've actually encircled the bleeding points. I don't know if I've made that point. You can pre-inject with epinephrine. Sometimes that works, but if there's really a lot of bleeding, typically you don't see them. The epinephrine won't work very well, and I think there was also a point that if you inject too much, the swelling becomes a little troublesome. You're concerned if your clips if your OTSC can actually be properly positioned. So I don't routinely use pre-injection. But that's just me. I'm sure others use OTSC their ways, and they seem to work as well.
Thank you very much. Dr. Meyer, do you have any comments on the practical application?
I would agree. I think it's the best thing is to not to do too much injection and try to shoot the clip right here.
One shot done.
We are a little bit over 5 minutes. We can continue to go. For anybody who has to leave strictly at 1:15, or I guess at a quarter past, depending on where you are, we thank you for joining us. And then similar to, a lot of the studies looked at the outcome of ongoing bleeding. So after an OTSC has been deployed, if that fails, what are the potential options, or what have you experienced in terms of how to manage either bleeding through the clip? I think some alluded to coagulation or other modalities that can be employed in the rare case of bleeding after OTSC deployment.
Guys, I apologize. I have to leave, not for a jury, but I have to go over and attend on cases here. It's been a real pleasure joining you. Thank you to Ovesco, Mark, and Christoph for putting this together, real effort, and look forward to hearing more from you and sharing these sessions. Thank you very much.
Thank you
Thank
very
you so
much,
much.
Dean. Big honor to have you here. Thank you. So there's the second questionnaire there. I just see. How did you like this webinar?
We hope this has been informative. And in the meantime, maybe Dr. Caca, tell us what your experience has been in bleeding after an Ovesco is placed.
We are using TTS clips or using a coagulation grasper. We were quite experienced with it because after FDRD in the upper GI tract, it's not seldom that you have some visible vessels, a little bit of oozing, and then if you have enough tissue above the clip, then coagulation helps a lot.
Is cyanoacrylate injection a point?
I wouldn't trust on this. I would
We had just
a
very
compression
few
or a
cases.
coagulation.
Yeah. Mm-hmm. Yeah, or take a large clip over it, like a large microtech or whatever, to really grasp the nodule inside.
I think one of the, in my experience, if the over the scope clip has failed, it's been due to severe bleeding, more in a delayed fashion. But the clip is excellent as a marker for the radiologists. So a lot of our patients have ended up going to angiography successfully. If there wasn't, the few that have that, if there wasn't effective hemostasis at a later point. We've been fortunate in our experience in New York not to have to send many patients to further to surgery as a result of their bleeding. But I think those are other things that, or other services that could be involved in care if repeat endoscopic modalities are ineffective, then radiology and surgery.
I think there are 2 points. There's a point where you have deployed the OTSC and you're off target. It's continuing bleeding because you're a little bit off target. You haven't put the vessel at the center of the cap and you're just a little bit off target. Then, of course, as Jürgen says, you take out the OTSC and put another one, maybe a bigger one above it. The other point is you have still bleeding above the claws. This is very rarely, and then we would do this coagulation or another small TTS clip.
Okay, and maybe one last question. I'll start this one off with Dr. Caca, since your study had included a second look, but just in general, and I don't think we have an answer to this, how long does the OTSC remain in the body?
I think we haven't got really proper data. We have only data from the FDRD, and especially from the FDRD in the colon when it pops off in 70% after 3 months. So, but sometimes in the upper GI tract after years, you can see the clip in situ. So I'm not really sure what the retention rate of the clip really is. Does anybody else have some data on it, James?
I don't have proper data, except I have patients coming back at the end of 12 months, for instance, demanding the clip to be removed. Not that they are feeling the clip, but then they somehow they want the clip removed. So they can stay for a long time. Yes, very, very long. But I don't have data, no.
Probably if it's longer than 6 months, you just leave it where it is. It's an nitinol, and so it's completely, you can use it as a permanent implant. If there isn't any obstruction, you don't need to remove it.
Dr. Meyer?
Yeah, same. I think we are talking about the same data from Ludwigsburg. With the 3 month, we know then the clip is gone in the lower GI tract. in a study from the upper GI tract when we examined like a resection of subepithelial tumors with the upper GI tract FTRD. The rate was even higher. Clips were gone in like 70-75%. But again, I have to agree. So we know all these patients with the clip in situ after several months or years or a year, and if there's no problem, then leave the clip there, right?
I agree. I mean, it's been variable in my own experience, but the times that I wanted it to stay on forever, it's always come off. So the irony, but yeah, I think that's something
totally understandable. Yes. Yeah.
That's something that can be a future direction, and potentially whether the type A or the type T tends to stick on more, or if size plays an issue. But I think this is something that we don't necessarily have the answer to, but regardless, they are MRI conditional, and they won't cause, as long as there isn't any obstruction to begin with, they shouldn't have an issue going forward. So with that said, we're approaching on half past, and I'd like to take an opportunity to just thank everybody and thank the Ovesco team for putting this together and for inviting us and for having our panelists who have shared their research and their success stories with the Over the Scope clip. Jürgen, any other afterthoughts on your end?
I think the OTSC is one of the most important tool in the armamentarium of the interventional endoscopist within the last 15 years. For me, it's certainly one of the really most important tools I have.
And as a general gastroenterologist, in the situations of bleeding, I absolutely agree. And even in other complications, that it's a tool that maybe we're not as familiar with or as comfortable with in general gastroenterology, but is well within our scope of practice, especially as people that treat variceal bleeding, and is potentially easy and to use and to learn, especially with the support of the Ovesco team and hands-on education. So with that said, we thank you for joining us and wish you a wonderful rest of your day.
Thank you to everybody.
Bye-bye.
Thank you. Goodbye.